well, spinal cord injuries. From black and mild to spinal cord injuries. All right, so this is specifically referring to just the spinal cord insofar as this isn't really talking about any of the brainstem stuff or the rest of the brain. So, which we will talk about next week. There's a lot of brain disorders next week is the first lecture. Usually these are in a pair, but I had to separate them out. Whatever. So we talked about spinal cord injury before. Do y'all remember which one? There we go. What about T6?
The neuro something.
Neurogenic shock. Good. Yeah. And we'll see that briefly mentioned today. But the same kind of concepts that apply to neurogenic shock are going to apply to these kind of stuff. It's a lot of keeping track of what it means and what it meant to be in shock for neurogenic shock. You have to keep up with like what it means for different other injuries, and then you have to keep up with where it occurred along the spinal cord. So it's going to be a lot of like, this injury happened at T6, and then it results in this and stuff like that, and just keeping track of what everything's caused and where the injuries occur. So spinal cord injuries at a glance, there's a lot of cases each year. It's estimated that there are a lot of people who are living with spinal cord injuries, and what we'll see is that drastically ranges in severity, where it ranges from everything from like really bad and paraplegics to people who just like have to monitor certain things throughout their life. But the average age of the time of injury is 43, which is relatively young for what you might expect. And the reason why, here you go. Yeah.
One year older than what that girl thought you were.
Oh yeah. I thought you were 42. So the problem is that a lot of like children make bad decisions, right? And they're also really, really active. So you can imagine things like sporting injuries if you're on a football field. And we got a Friday Night Lights situation. Have y'all seen that show? Joking. It's like, yeah, the first episode, the star quarterback gets tackled and he gets like a spinal cord injury. He becomes paralyzed the rest of his life. It's called Friday Night Lights. I don't know, whatever. So a lot of like young people are playing sports, get injured there, get dry, and so they get in bad car wreck, and do stupid stuff on the lake and get in bad wreck. Like they do stupid stuff because they're peacocking, and so there's a lot of like injury at a young age with that. And so that's kind of what you're looking at with a lot of these injuries as healthcare providers. So it's a lot of like 20-year-old people coming to the hospital. It's a lot of males as well, because guys are idiots. Simply put, compared to females. I forget. Is there anything else here? 43. Yeah. So, it's a lot of vehicular and falls, but some of it is sports and violence related. So just a review of what the spinal cord looks like. Y'all don't really need this review, I suppose, but different parts of the spinal cord regulate different parts of your body, and from nerve innervation, and they're all classified based off of the type of bone that surrounds it, about where you are along the body, right? And so when we talk about that T6 vertebrae, we're talking about that spot. And so we're just going to have to, so you can realize that like, what we'll see throughout this lecture is that the lower you are on the spinal cord, the less damage it does, generally speaking. Insofar as like everything above that spot in the spinal cord is going to be normal functioning for the most part. Now it's not that black and white, but that's a good general rule to have. Additionally, that kind of correlates with the severity of the spinal cord injury at where you are on the body as well. But we'll see that. So there's different dermatomes that regulate this, the spinal cord regulates, which you should generally know about. But then there's different groups of these dermatomes that come together. And it doesn't really make sense if you just look at a picture of a body standing up like that, but whenever you realize that we evolved from quadrupeds, you can kind of see that it just gradates based off of front to back if we were like a dog's type of body shape or functioning. Because that was pretty late on in evolution, was standing erect, right? Well, in bipedal movement. So that's kind of how you can justify the weirdness of the dermatomes. But
Why is that in Spanish?
what?
It's in Spanish.
Oh, it is. I totally didn't. I just saw this picture online and I was like, oh, that's funny.
That's how you pronounce that.
Sure. I trust you. I never took Spanish. Okay, so what a spinal cord injury is a complete or partial damage to the neural elements of the spinal cord that cause permanent changes in the sensation and loss of voluntary control below the site of injury. Right? There's just a whole bunch of words of a pretty intuitive concept. Vertebrae can be fractured by trauma, but unless the spinal cord is injured, there will be no motor. Right? So you can fracture a vertebrae without necessarily losing spinal cord function. Right? It's not impossible, but usually if it's bad enough to break a bone, it's gonna bad enough to cause spinal cord injury, but not impossible. So there's different types of spinal cord injury as far as where you're coming from. There's so it's based off of like how the force is applied to the spinal cord, right? And so if you're applying straight on blunt force, what happens is that the momentum carries your head, but if there's a stoppage of your body, you provide that like counter force right there, and your neck falls victim to it. There's also this like extension hyper extension thing where you can fall and then just it goes too far back, and so you're actually there's not a lot of bone injuries with this as much, but there's a lot of spinal cords injuries to where on your vertebrae specifically, and there's like a compression because you're going backwards, and so you're compressing that spinal cord too much. There's also compression, where you can kind of see the picture, you're literally compressing it head on to whatever that axis is. And then there's rotation that you can imagine if you rotate too much, you can sever a spinal injury there. So there's different like classifications of how you injure it, but we're more concerned about the pathology of what happens than that, so you don't really need to know that. There are two different types of spinal cord injury as far as there's primary and secondary injury. Primary being the actual cause of whatever's the mechanical causes like damage to the area. So this is vertebral fractures, external lacerations, contusions, cord lacerations. So this is actually like literally damaging the neurons, right? But that contrasts to secondary injury insofar as like you can imagine if there's a little bit of injury and then your immune system comes in and releases a whole bunch of inflammatory mediators and causes inflammation. It'll cause a whole bunch of pressure, and then because there's an increase in pressure, things aren't functioning properly. You don't get proper signal transduction from neurons, yada yada yada, to where it's like oxidative stress also can kill things later on. So it's not all immune mediated, but this is like because there's a little bit of an injury that little bit of injury starts to snowball outward and cause subsequent damage downstream. That would be a secondary spinal cord injury. As far as trauma goes, there are 4 different levels depending on severity. There's hyperacute, which is instant. This is like you can imagine. I don't know how to put this lightly, but like this is like how fastly you die, kind of type of stuff. But it's not doesn't have to be that dramatic. But there's hyperacute where the damage causes. Here you go.
initiates a massive biochemical cascade resulting in immediate and progressive changes in the cord environment. There you go. So this is like how fast those changes in the cord environment progressed. And so if there's hyperacute that's very, very fast, this is things like getting in a wreck and just dying from a spinal cord injury in a wreck type stuff. There's acute where you've had damage that then has a whole bunch of proteins and blood components come into your spinal cord, and then you release a whole bunch of excitatory neurotransmitters, and then the problems results from that damage from there. So seconds to minutes. There's subacute, which is a few days to weeks, where you're actually have an immune response, so a lot of secondary injury occurring here. Blood, spinal cord barrier, breakdown, inflammation, vicious cycles, a lot of neuropathic pain. And then there's chronic, where you're lasting months to years, where you have decreased neurotropic support, scar firmly established, demyelination, and axonal growth failures. So,
have you ever seen spinal cord? Like a road? Have you ever
not a human one for sure.
You've seen them in that building.
Oh, really?
They're kind of small.
I've seen different. I've seen other vertebrates, I suppose, from like anatomy or physiology classes, from like labs and stuff. Like you're dissecting a frog and stuff. They're pretty small, you said.
Mm-hmm.
Okay.
Well, they're lengthy, like inches. They're smaller than what I would have thought.
Yeah.
And it really does look like a little horse tail.
Yeah. Okay. Interesting. All right. So this is what I was kind of referring to as far as the severity of the spinal cord injury correlating with where it occurs more than anything. So the level of spinal cord injury and the effects. So alterations of the body functions that result in spinal cord injury would depend on the location and severity. So the lowest part of the spinal cord that functions normally after the injury. So there's this neurological level of injury. So typically, if you have a spinal cord injury that happens like boom right here, let's pretend. Typically, everything below it, because the way that nerves are sent from the brain through the spinal cord, everything below it's going to be dysfunctional. So what the neurological level of injury is referring to is how far can signals go down the spinal cord before they stop transmitting properly, right? And depending on where it is, results in different levels of injury. So usually, again, like I said, the lower levels, because those regulate, right, the like hips and below, and then or the waist and below, and then like your hips and below. If it occurs right on this lower half, typically the problems are only localized to the lower half of the body. But if it involves higher injuries, then it can affect your whole body up to that. And so there's these different. The two major categories here are tetraplegia and paraplegia. Tetraplegia is where you have an impairment, damage to neural structures, just affecting the spinal cord, the arms, trunks, legs, and pelvic organs are affected. While paraplegia is just in the legs and the pelvic organs, right? And so it's just the lower half of the body compared to generally the whole body. But it's not always, but obviously this is a simple diagram. It's not always just black and white. You can also affect left sides and right sides more. It starts to get there's also like transmission back upward to the spinal cord. So it's a complicated issue here. But we're just going to kind of go down various levels of injury that occur. So you can kind of see that these are your benchmark spots. And so this is what I want you to know is that like if you're affecting C1, that's going to be like your whole body effectively, right? Because it's so high up on the spinal cord. But if you're C5, that's only going to affect these where you see the different graded areas, right? And so T2 is going to be, I guess they're all gray. Can't see my mouse. I don't know. But as you go down, it's going to affect different severities of the body. I guess we'll just leave it there. So there's also complete and incomplete spinal cord injuries. So a complete spinal cord is where you have loss, sensory, and motor function are all lost below the spinal cord injury, right? This is where like you have an injury and then you just can't, everything below that spot is affected and it's just paralyzed, right? You don't have any control over any of those organs and I don't know, just say organs, right? But there's also incomplete where you have like some function can remain, right? Where you can have some level of control. Like you can imagine like having slight movement of like a finger, but you certainly can't do this, right? Or like you can move one finger but not the rest of them type of injuries. And then imagine that in other organs, and it can really affect it. So there's this zone of partial preservation, and those are the domatomes and myotomes that are caudal to, so like the tail end, caudal to the neurogenic level that remain partially innervated in incomplete injuries. All right, so spinal cord injuries, you can imagine the big thing is loss of movement to where you can't move the things, right? A lot of times spinal cord nerves are going to innervate muscles, and there's also other organs that we'll talk about that get innervated by nerves, and so you can lose like loss of a lot of other organs, but movement's the big one. And then your ability to feel. So loss of sensation, including ability to feel heat, cold, touch. And then we'll talk about loss of bladder and bowel control pretty extensively. And then exaggerated reflex activity or spasms, changes in sexual function, fertility. And then you're going to have pain also as well in the head, neck, or back. Right. If these neurons innervate things like the lungs, you can also have trouble breathing, right? Because it's your intercostal muscles within your rib cage that allow for expansion of lungs, right? And so if you lose that innervation, you can have breathing either in or out or coughing. And we'll talk briefly about how like those muscles are really important for coughing, which is a great way to remove bacteria and other particulates. Well, if you can't cough, then those bacteria are really given a great exposure for an environment to replicate. And so people with spinal cord injuries can have a lot of bacterial infections, especially in the lungs. Numbness, tingling in fingers, oddly position, twisting, neck or back, weakness and incoordination or paralysis in part of the body. So I imagine y'all don't really want to see a lot of other questions since we took the test today. But a spinal cord injury resulting in some motor or sensory function below level of injury. So this is where you just have some. And so what do we think this is? Incomplete, complete, or secondary neurologic injury? Yeah, it's going to be incomplete. Secondary is referring to like if you have inflammation, right? Type of stuff. But yeah, this is because it's only some motor or sensory function. It is an incomplete type of. We won't have to go through this. It's fine. So we're going to talk about some complications because of spinal cord injury. The first being autonomic dysreflexia. So dysreflexia, you can imagine, is that your reflexes are not functioning properly, right, on an autonomic level. So it's a very serious condition. So it's at or above the T6 level. I don't know how. Something I am curious about that I need to look into is how autonomic dysreflexia is related to other spinal cord injuries and if they're correlated with neurogenic shock, if it's affecting the same level of injury. But I don't know the answer to that, if you are also wondering that. But what it does kind of fit, though, because one of the big things, or the big thing with autonomic dysreflexia is that you have severe increases in blood pressure. You have baroreceptors in the vesicle, and right, so that makes sense because when we talk about neurogenic shock, that's like the big thing is that you're not getting proper blood flow to the organs of your body, and that's what shock truly is. And so, if it's regulating blood pressure, you'd think that they'd maybe be related in some form or fashion. But regardless, you have these baroreceptors in the vesicles send signals to the brain, which sends message via the parasympathetic vagus nerve to the heart to slow it down. So the result is high blood pressure and bradycardia that can lead to a stroke, seizure, or even death, right? And so this autonomic dysreflexia is a very severe thing. So when you have dysreflexia, there are three things that it causes, and it affects your bladder, your bowels, and your breakdown of the skin. So with the bladder, you need to make sure the bladder is emptying properly, and we'll talk more about that in a little bit. And you want to look for signs of infection because that's one of the ways that your bladder removes bacteria and pathogens is that it's taken out as the urine flows over it. And so there can be some urinary tract infections if the bladder isn't working properly. There's also the bowel, which you check for impacted stool, palpate through the abdomen to make sure that bowel movements are occurring. And then break down the skin, assess the skin regularly, protect from injury, remove binding devices. And we'll talk briefly about that one as well. So we're going to talk about more about these. But signs and symptoms of autonomic dysreflexia is it's kind of listed here. We won't go into all of them, but I do want y'all to know that it's mostly related to blood pressure, and so you have pronounced bradycardia and irregular heartbeats, but then it also can cause things like headaches as well. And they have different combinations of this, one, several, or all of these symptoms with each autonomic dysreflexic episode. So, whenever people do have these spinal cord injuries, there's this respiratory dysfunction that I kind of mentioned here. And so this is patients are most vulnerable to respiratory illness in the first year after injury, but continue to suffer from respiratory complications throughout life, right? So this is like the most common cause of death from spinal cord injury is this respiratory illness. It's just your inability to remove these pathogens from the respiratory system. It's an important thing to know. And so what I mentioned earlier is what's going on, right? When you don't have control of your coughing sensation, it allows for an environment of growth of these pathogens and then can just cause death subsequent to that. And so that's what the respiratory dysfunction is, where okay, I kind of went over this. Intervention of the abdominal muscles comprises the ability to generate coughs, right? Injuries above the C3 are virtually complete paralysis of both muscles. So this is what you kind of have to do when you study, right? You have to make sure you know what respiratory dysfunction is, why it's a complication of spinal cord injuries in this first paragraph, and you have to know what level do these injuries occur at to cause these things, and that'd be C3 here. A patient with complete T12 classification will have no respiratory or expiratory impairment, right? It's because that's below the level of where the intercostal muscles are innervated by the spinal cord. And then clinical signs that you have respiratory problems, change in respiratory rate, shortness of breath, increased heart rate, because you're trying to pump more. Your breathing is going to be affected. It's not just coughs and infection. And so you have increased heart rate to try to get more blood to the lungs, increased anxiety, increased volume or thickness of secretions, decreased oxygen saturation, and elevated temperature. Yeah, you're not getting oxygen to your body because you're not respirating properly. So the next one is neurogenic bladder. So this is where you can't really control complete or partial loss of bladder control, right? Resulting in incontinence, renal impairment, urinary tract infections, because your urine washes away those bacteria. poor quality of life. So what's going on here is so there's different types of neurogenic bladder. So this is what normally it looks like, normal function. You just have everything innervating the bladder correctly, right? But there's different levels. There's different stress receptors, and that's how your bladder communicates to your brain that it's ready to be either relieved, and that's why like you have the sensation of needing to go to the bathroom, or that it has been relieved and you can stop going to the bathroom. It's positive and negative controls at its finest. The problem is that if you have injuries above these sites, what happens is that you don't have pretty much any control of your bladder function, and so it just is constantly relieving itself as it builds up, right? And so you don't have any problems in that. It's like you're relieving all your urine, you're still getting rid of all the waste products, but the problem is you have no control over it, right? Another problem is just injuring below those L1 and L2 to where your bladder's filling, but it's not communicating to the brain that it's filled, and so there's never a release of there's never like a communication to your brain that you need to go to the bathroom, I guess is what I'm saying. So the bladder reflex is absent and you retain all your urine. So in both instances, many people must be catheterized. So this is just relieving y'all know what a catheter is, I imagine. It's just relieving all that urine, so there just doesn't need to be any control, whether it be you're retaining the urine or you're just constantly relieving. It's just always being regulated in a manner. Does that make sense? Okay. All right. So with neurogenic bladder, the problem with that is that there's a lot of we talked about a lot of these signs here. You have an overactive bladder or urinary retention. You have dysuria, so it's painful or difficult to urinate. And then there's also can be bacteria that grow, or bacteria or other pathogens that grow. You can have malaise, fever, chills, and you have immune reactions to that as well. UTI infections, sepsis, kidney bladder problems. So neurogenic bladder contrasts to neurogenic bowel, in which case your bowels aren't innervated properly by your spinal cord. And this is like, from what I've heard, this is like the thing that most people are most bothered with spinal cord injuries. They can like learn to deal with the loss of like mobility and the lack of sensation and but like the social implications of just relieving your bowels in front of people and you not knowing it, it's like it's got to be awkward. So you got to feel for these people. But apparently there was a video I watched that it's a lady who treats people with spinal cord injuries, and she says that like patients are most embarrassed by this, and it's like the hardest thing to kind of deal with. So but it's just a complete or incomplete loss of your bowel control, right? And in patients with up to 95% of people report constipation, and 75% have experienced episodes of fecal incontinence. Only 6% of patients with spinal cord require no intervention to support their bowel function. So it's a very common thing. It's more problematic than any of bladder dysfunction, sexual dysfunction, pain, fatigue, or perception of body image. This is like the number one problem that they have with this life-changing injury. So just like with the bladder, though, you can have hyperreflective bowel caused by a lesion above the T10, and you have involuntary contractions of the muscle of the rectum and anus, and so they're not contracting at all, right? And so you don't have that proper peristalsis that moves waste through the alimentary canal. And that contrasts to areflexive bowel caused by lesions below the T10. So the T10 is the major one for neurogenic bowel, and loss of peristalsis and slow stool propulsion, leading to constipation with leaking of stool. So neurogenic bowel. So the signs are going to be constipation, abnormal distension, respiratory compromise, evacuation difficulty, unplanned evacuations. I think, but by evacuations I mean like defecating, right? And then rectal bleeding and pain. And the last thing we talked about in that slide, we said there's problems with the bowel, there's the bladder, and then we said the skin. And the skin is less like intuitive, I guess. But the problem here is that when people can't move and they're so stationary, your skin isn't supposed to sit with constant pressure in one spot necessarily, except for maybe your feet to a certain degree. But the problem is that if you're laying down like this all the time, there's these pressure ulcers that develop, and you can kind of see a picture of them here. These pressure ulcers develop on localized injuries to the skin, underlying tissue resulting from prolonged pressure on the skin. So it's these people that are laying in bed so much that these pressure ulcers pop up. And so what a lot of people have to do is come in and then like either rotate a patient or like flip a patient. There's numerous ways you can deal with it, but you don't want to have prolonged pressure to one localized spot. The problem spots mostly are kind of here, right? The back of the head, the heels, and then your shoulders and the waist area where you have that's mostly where you make it's a lot of curvatures happen there and of concave origin, and so that's where most of your pressure is going to rely, especially on like these shitty hospital beds, right? That don't provide they're no Tempur-Pedic, we'll just put it that way. And they can develop quickly. Man, I'm really jumping the gun on these on this lecture today. So regular frequent skin. So yeah, you want to check frequently, and then patient repositioning schedules. That's what I was referring to. And then you can use pressure reducing services, assess nutrition, and provide supplementation as needed. So this is a cool website. I meant this happened last year too. I meant to put this in the skin. Skin disorders lecture. But this is a cool website. It's like you know, we say that like we always show pictures, and I try to make an effort to not do this, but there's a lot of pictures in healthcare that show of just Caucasians getting rashes, and Caucasian rashes and African American rashes are very, very different, right? And so this is a really cool website that shows what different rashes look like on different skin tones, whether you're black, brown, or Hispanic. No, is Hispanic brown? I don't know. But what's Indian? Oh, Middle Eastern, Indian, and Hispanic are all classified as brown. I guess I don't know. I'm bad with politically correct stuff. I try, but I fail.
As long as you try.
But anyway, this is a really great website that you can note to like see what different conditions look like to different skin tones. And then I don't know what this is. People want their recovery priorities of SCI populations. Oh, yes. So this is like what people want to have recovered after they lose things, and this is priority to like maintain a little bit of a semblance of a normal life. And so you can see the big thing is the hands and arms, because you just want to be able to feel, touch, and move things. Laying there just solitary is got to be a tough a thing. But if you can at least move your arms, you can get a wheelchair and different stuff like that. So this is just kind of a list of like things that people wanted to be dealt with. And so, yeah, it's just kind of a little fun fact. But people really, yeah, this is the big thing. People who have this, the thing is that these injuries occur so spontaneously, and it's just so life altering when you're probably doing something innocuous, like driving, like having a day at the lake with your friends, like playing sports. So it's just like you were just having a weekend, and then your life is just upended. And so people, a lot of dealing with this is also dealing with the psychology of having that fundamental change in your life, and people just want to have a little bit of independence and dignity within that. So, but that's it for today.
I wonder what guys are gonna, cause you know now like if you rape someone that's under the age of like 13, I think, you get like your penis chopped off. Castration.
Is that a thing?
Yeah. Physical castration. Yeah.
Is it the law now?
Yeah.
That's crazy.
It's about to be. I can't
Sure.
wait for it.
I wish the egg was tired.
Yeah, same.
That
I
is.
am pro castration.
And female.
Yeah.
All right. Sure.
I'm pro.
Well, I mean, we can't get
No.
anything chopped off, but you know, all men.
Well, you can get.
You can
females
chemically cast it,
no,
right?
Females can get circumcised.
Oh, they're crates?
Yeah, basically.
Um,
that in the West.
Uh-huh.
I did just follow a Instagram account where it's predators getting caught, and I don't know why, but that's like the one crime show I'll watch. Not a crime show, but
I mean,
it's something just so I don't
Is it
know.
the one where like all the people come with cameras?
No, it's this dude. It's actually kind of funny. So he like it's a dude who impersonates like a 12-year-old or whatever, and then they're like, hey, you want to meet up in this public place? And then these dudes like, yeah. And then this dude just like starts slapping him. He's like, what are you gonna do? I'm gonna call the cops on you if you. I'm just like, I don't know why this doesn't feel as wrong as it should. It's like,
I mean, but castration is like.
I wonder if they
awesome.
for child rapists,
Oh,
sure.
for rapist period.
For
I
rapist
mean,
period, sure.
Even if you're going to jail, like you still can have anal sex.